Hi everyone, my name is Zuhur Jeshi and I'm going to go over my Iron IRB proposal presentation today. So first of all, I'm going to start with some background information about iron. What is iron? It is an essential nutrient that participates in oxygen transport, the DNA synthesis, and the electron transport chain, and it is needed by all living organisms. So any deficiency or toxicity due to the importance of iron can actually yield some serious conditions. What are the metabolic disorders then of iron? They can be iron overload, secondary hemochromatosis, which is due to excess iron deficiency anemia, which is due to deficiency or low levels of iron, anemia of chronic disease, and iron overload with anemia. Moving on, what is the etiology or the causes of iron deficiency anemia? They can be increased demands, basically among children who are growing and developing. Those children need large amounts of energy, and when those large amounts of energy are not met, these children are prone to suffering from iron deficiency anemia. Another cause is limited supply due to poor diet. The limited supply can be socioeconomic, or it can be attributed to one's distorted self-image, basically individuals who suffer from anemia or bulimia, also individuals who are following severely restricted caloric diets. Drug interference, some drugs can interfere with the absorption of iron. Malabsorption due to gastrointestinal diseases or bacteria like the Helicobacter pylori, and increased blood losses due to trauma, sudden surgeries, or any other conditions that can cause heavy blood loss. Signs that indicate the presence of anemia are three main or fundamental signs. Brittle nails, which are the tendency for the nails to break easily, and they also tend to form several layers in each fingernail. Pale skin or a sore tongue. It is the redness or the swelling of the tongue. The clinical symptoms of iron deficiency anemia are chest pains, chills, headache, fatigue, dizziness, irregular heartbeat, pica, and shortness of breath, which is accompanied by weakness. Now, pica is actually the tendency to consume non-food items. It can be dirt, paint, or even ice. The populations at risk are menstruating women due to the monthly blood loss during menses, pregnant and breastfeeding women due to the increased demands, celiac disease patients. Celiac disease has been linked to the malabsorption of several nutrients, and one of those nutrients is actually iron. Crohn's disease patients. Crohn's disease patients suffer from prolonged damage to the small intestines, and since the small intestines is the site where iron is absorbed, this can actually affect its absorption and cause iron deficiency anemia. Bariatric surgery patients and vegans and vegetarians, mainly due to the fact that they do not consume animal sources of protein. Now, the diagnosis of iron deficiency anemia: when an individual presents with the following, he or she may be iron deficient. It can be low hemoglobin and hematocrit, low mean cellular volume, low ferritin, low serum iron, high transferrin, and low iron saturation. The dietary sources of iron: from animal sources, it is lean beef, oysters, chicken, and turkey. They are the heme iron. And from plant sources, it can be beans, lentils, tofu, baked potatoes, cashews, dark green leafy vegetables like arugula, fortified cereals, and enriched breads, and those basically form the non-heme iron. Now, iron absorption in the body: 10% of iron is absorbed from a typical diet, which is not much actually. The absorption takes place mostly in the intestines, in the duodenum, and the proximal jejunum parts. There are two forms of iron, the Fe3 plus and the Fe2 plus, both of which are non-heme. Non-heme are usually associated with storage proteins, whereas heme are associated with myoglobin or hemoglobin. The acidity of the stomach dissociates heme from hemoproteins like hemoglobin and myoglobin. And regarding non-heme, it is usually reduced to Fe2 plus, which is its more stable form. Iron import proteins are found on the brush borders of enterocytes. Once the iron is in the enterocyte, it should be exported to circulation, and this is mediated by FPN1, which is a unique iron export membrane protein. The cellular iron concentration induces FPN1, while hepcidin suppresses it by binding to its cell surface and inducing its internalization and following lysosomal degradation. Once iron is exported by FPN1, it is transformed to its ferrous state by peroxidases. This allows it to bind to transferrin, which is responsible for iron transport in the plasma. The iron and transferrin then bind to the transferrin receptor and they form a complex. This complex is then internalized within the cell and the transferrin is then released at the cell's surface. Then, how is iron stored in the body? First, it should be reduced from the ferrous state to its ferric state, and then a family of ferroreductase proteins transport iron to the cytoplasm. Ferritin is stored in the bone marrow, the liver, the spleen, and skeletal muscle. Discussing iron homeostasis in iron deficiency anemia. Erythropoietin hormone is released and it inhibits hepcidin to increase iron gain. Now, what is hepcidin? Hepcidin is actually an iron regulatory hormone that functions to inhibit iron absorption in the proximal small intestine and iron release from macrophages. So hepcidin, in other words, is an indicator of iron deficiency anemia. Moving on to the literature review, the point of the literature review was to look at studies that evaluated whether or not there was a positive correlation between the consumption of vitamin C and an increased absorption of non-heme iron, basically because the question that was studied in the paper was whether or not an introduction of 1 gram of vitamin C increased non-heme iron absorption among women who were older than 18 years old. A recent article states that ascorbic acid, which is vitamin C, is the most efficient enhancer of non-heme iron absorption. A study conducted among 81 children between the ages of 6 months and 12 years aimed to study or to compare the efficacy of ferrous ascorbate and colloidal iron in the treatment of iron deficiency anemia. And the results showed that vitamin C played a significant role in treating iron deficiency anemia. Another study focusing on the effect of vitamin C intake on non-heme iron absorption from a complete diet showed that vitamin C supplementation had a significant effect on iron absorption long term and from a complete diet rather than just meals. Moving on, a study conducted in Nigeria among 74 pregnant and 20 non-pregnant women aimed to look at the role of vitamin C in the prevention of iron deficiency anemia. And the results of the study showed a positive correlation between serum iron and vitamin C, meaning that a decrease in iron stores called for an increased need for vitamin C. Therefore, vitamin C was enhancing iron absorption. Another study conducted among 25 healthy children between the ages of 3 and 6 years aimed to study the effect of orange juice and apple juice on iron absorption in children. The choice of orange juice and apple juice was basically to look for the effect of vitamin C, which is mainly present in orange juice. The results showed that iron absorption was enhanced when meals were accompanied by juices that contain vitamin C, so thus reinforcing the notion that vitamin C has a positive effect on iron absorption. Similarly, another study among 21 children between the ages of 4 to 8 years studied the effect of vitamin C coming from orange juice on iron absorption in the form of ferrous fumarate. The results showed that iron absorption increased when meal consumption was accompanied with orange juice as opposed to apple juice. So basically, the iron absorption was higher when the meal was accompanied by orange juice. The methodology of this study, this is a quantitative randomized clinical controlled trial. IRB approval is required since human subjects are involved. The recruitment place will be a primary care physician's office, and baseline questionnaire is required by the participants. The baseline questionnaire will include questions about dietary habits, physical activity levels, any medications or supplements the individuals are taking. The hypothesis. The alternative hypothesis is that vitamin C supplementation of 1 gram per day increases non-heme iron absorption among women older than 18 years, while the null hypothesis is that vitamin C supplementation of 1 gram per day has no effect on non-heme iron absorption in women aged older than 18 years. The eligibility criteria: women above 18 years old, non-pregnant, non-smoking, iron deficient, and not taking any medications or supplements. The exclusion criteria is failure to complete the questionnaire, age younger than 18, women suffering from cardiovascular health conditions, and if they do not have iron deficiency anemia, then they are not eligible. If they are pregnant or lactating, then they will also be excluded. Each participant will be randomly assigned a number to present her as an entity in this study. The participants will follow general guidelines for a 1,200 calorie diet with 5 servings of carbohydrates, 3 servings of fruit, 4 servings of vegetables, 4 servings of lean meat, and 3 servings of fat. The study duration will be 6 months. Group A will receive 1 gram of a daily dietary supplement of vitamin C, while Group B will receive a placebo pill. The number of participants will be 210, with 105 in each group, Group A and Group B. This will be calculated using G-Power with an a priori test. The CBC will be taken at baseline, then again at 6 months. It will basically include the levels of hemoglobin, hematocrit, transferrin, mean cellular volume, and iron saturation. Monthly food frequency questionnaires will also be filled by the participants to measure their adherence to the diet. The results will be analyzed using G-Power software. A two-tailed t-test will be used to assess the pre-intervention and the post-intervention, the differences between both groups. Hypothesis will be tested using a post-hoc two-tailed t-test with a power of 0.5, alpha of 0.05, and a median effect size of 0.5. If p-value is less than or equal to alpha, then H0 is rejected and H1 is accepted. And if p-value is greater than alpha, then H0 is not rejected and H1, the alternative hypothesis, is therefore accepted. The anticipated findings are to establish that there is a positive correlation between the consumption of a daily vitamin C supplement and an increased rate of non-heme iron absorption among women older than 18 years. This study will, however, have some limitations. The food frequency questionnaires can be subject to bias as they are submitted by the participants themselves, so they may under or overestimate their intakes of the servings. Another limitation that can act as a confounding variable is the consumption of foods that act as inhibitors to iron absorption, basically calcium and tannins. A recent randomized single-blinded trial conducted on 27 women of childbearing age between the ages of 34 and 45 were introduced 800 milligrams of calcium to their diets, and the results showed a decrease in non-heme iron bioavailability. So basically, calcium affected iron absorption, non-heme iron absorption. Another dietary factor is, as mentioned, tannins, which are found in tea, since tannins also have an inhibitory effect on iron bioavailability. The ethical considerations in this study, as mentioned, are IRB approval because the study involves human subjects. The study should also follow the Belmont principles and protect the participants' anonymity and confidentiality. The participants should fill a consent form prior to participation. This consent form will include information about the study and what is expected of the participants, the duration of the study, and any concerns that they may have. The references that I used for my presentation are the following. I really hope you guys enjoyed, and I'm looking forward to hearing your feedback. Thank you.